Hello everybody and welcome to the Primary Care Behavioral Health Integration webinar. It looks like most of the registrants have signed in, so we will go ahead and begin. So for behavioral health primary care integration, the goal of the projects are to integrate mental health and substance abuse within primary care services to ensure better coordination of care. The project has a list of requirements and milestones as well as metrics. On the screen you'll see the link where you can find that document. It's in fact the same document that your project planning teams would have referenced last November, December as you were preparing your project plans. At this point in time, the PPS has behavioral health primary care integration projects planned both under Models 1 and Model 2. In Plattsburgh, Queensbury, and St. Lawrence, both models are being planned. You'll recall that Model 1 is putting behavioral health services into primary care, and that Model 2 is putting primary care into behavioral health. In a couple of the other regions, in northern Adirondack and in Fulton, we're looking just at Model 1 right now. What we're asking the project teams to do at this point in time is a couple of things. One is budget and one is speed and scale. For budget, the budget template was released last week, an updated version. Some of you may have attended our meeting in Lake Placid back in February, a few weeks ago. At that meeting, we went over a budget template and there was a PowerPoint and instructions. Lynn Wadley, our CFO, walked through that budgeting information. She made some minor, she made some minor updates to the template in order to address a couple of the questions that were asked at that meeting. So the budget template has been updated. I'd encourage you to download that as well as the PowerPoint that's on our website and take a look through that information. If you'd like, in addition, there will be a webinar this Friday on March 6th from noon to 1 p.m. And during that time, Lynn will walk through that information and be available to answer any questions. If you did take part in the Lake Placid meeting, you may not need to attend the webinar, unless you have questions. So the templates are due back to AHI on March 13th, and the instructions for how to submit are shown on the screen. A couple key points about the budgeting process is that the budgeting process is iterative in fashion. You can think of this as your initial budget for your project team. It's not your final budget. It's not a guarantee that all the costs that are in it will be covered. The way that it's working with the development of the PPS budget is that each time we submit to DOH, they ask for an increasing level of detail. So at this point, what we're preparing for our April 1st submission to DOH is that the finance work group has to determine how many funds in total are going to be allocated to the project budget category. So what they're really looking to get a good sense from you as a team about your costs, and it's again, it's not your final budget. There will be a more detailed budget that's submitted at a later date. And at this point, those budget templates are submitted for the project, really for that project implementation as a whole. So they're not, you don't have to specify which particular partner is going to incur the cost. Just what are all the costs that you expect that project will result in, as well as the associated revenue. One of the questions that came up at our Lake Placid meeting regarding budget was people had asked, do I need to portion out those expenses such that I'm only budgeting for the proportion of a staff person's time that would actually be dedicated to serving Medicaid beneficiaries? And the answer to that is no. You don't need to do that. So we fully recognize that any given project is going to serve both Medicaid and non-Medicaid populations, and you don't need to parse out the proportion of say, a given clinician's time that might specifically be dedicated to Medicaid patients. You can include your costs, and you'll see there's revenue in those as well, your costs and your revenue as a whole. So we'll move on now to speed and scale. Speed and scale refers to the portion of the implementation plan where we explain to the Department of Health the speed at which we'll achieve the implementation. That is, when will we meet all the requirements for the project? In scale, it references, how many patients or how many persons will be impacted by this project. So we have a template for you to complete for project speed and the scale of the patient engagement. I'll walk through that template with you in just a minute. The template, you'll complete the template and submit it to the email box you see on your screen, and this item is also due on March 13th. So there are a couple things that you would need to know to be able to do your speed and scale template, and one of them is, what is the counting methodology that DOH applies to this project? So for primary care behavioral health integration, the counting methodology is method 3. Method 3 is a count of patients that meet the criteria over a 1-year measurement period. So how many patients count as actively engaged over the course of 1 year? And we can't count the same patient twice within a given year. And the count is not additive across the district years. So you'll see what I mean in a minute when we get an example of the template on the screen. So here you see the sample template, and let's start off with the patient engagement section of this template. So the section on the bottom half of the screen. So you see the definitions for actively engaged are given on the template. For Model 1, the definition of actively engaged is the number of patients that are screened with the PHQ-9. For Model 2, where it's a behavioral health site and primary care is co-locating into that site, for that model, actively engaged is defined as the number of patients that receive a primary care service at a participating mental health or substance abuse site. So the two definitions are in fact very different, and this is partly why we need a separate speed and scale implementation table completed for each given implementation of the project within a specific region. So you're going to be filling out the template for once for your project team that is doing either Model 1 or Model 2. If you're participating in both models with different groups, then you would be part of more than one template that's being submitted. So for the patient engagement speed section at the bottom of your table, the numbers that are shown in red are the numbers that represent the actively engaged patient commitments that have already been made at the network level. So back in January, AHI had to submit a speed and scale template for all of our projects. We built those numbers based on the templates that the project teams had submitted to us back in December. So we looked at the information that was in those templates. We understood that there was some confusion regarding the counting methodology and how those numbers and whether or not those numbers were additive over time. In fact, there was a whole series of communications and webinars from DOH to clarify the counting methodologies, and those were not even final until January. So we did look at the numbers that you sent us, but we didn't simply add them up. We applied some rules and tried to make sure that the numbers were in fact reasonable numbers, given the partners that were participating in the expected capacity. So you won't simply be able to take the numbers that you gave to us before, sum them up, and get to these. Another point on the strategy of these numbers, I just want to point out that we were advised to put in as low of we were advised to put in conservative estimates. And the reason for that is that the payments to the PPS in part depend on whether or not these numbers are met. So it's not the only factor, it's one of many factors, but we will be, the state will look at these numbers, and part of the payment will be withheld if we don't meet our targets. So it was important to be able to meet the targets, so we tried to put reasonable and achievable numbers into the speed and scale submission in January. Overall, our project scored well in our submission, so we were comfortable with that approach that we took. And I point it out to you now in part because when you get your template and you look at these numbers, they may seem low to you, but that's okay. We can exceed them. In fact, you should think of these as minimums. These are minimum numbers that we're trying to achieve as a network. If we exceed the numbers, that's great. Not only does it mean that our payment wasn't impacted, but it means we may have the chance to earn high-performing bonus payments from the High Performance Fund. So that's how we got to these numbers. In reference to the counting methodologies that I just described, I just would like to walk through the numbers that are in red to make sure that the counting methodology is clear to everybody. So back in January, these are the numbers that we submitted, and at that point in time, we had to submit numbers per each 6-month period. So that's why you don't see them for every quarter. You only see them twice a year per each 6-month period. So what you can see here is that in DSRIP year 2, by the end of the second quarter, so that is by the end of June during DSRIP year 2, we had committed to actively engaging 8,274 patients in this particular project. By the end of that calendar year, by the end of December in DSRIP year 2, that number has climbed to 20,684. So these are numbers that essentially reset to zero the following year. So DSRIP year 3, you can think of it as that the counter has reverted to zero, and now during DSRIP year 3, our commitment is to have met that actively engaged definition for a total of 15,700 some patients by the end of June and upwards of 31,000 by the end of the year. So you can see how the counter then reverts to zero again for DSRIP year 4, and the first half of the year we would expect 22,000 some patients have met that definition. So in effect what you're seeing, because the commitments made in the first 6 months of each year grow over time, we're basically showing that we expect to be increasing the capacity of the program and the project and increasing our ability to engage patients in the project as the project goes on over time. So what we need to do now is we need to have each planned implementation provide back to us estimates of the numbers of patients that they'll be able to actively engage over the course of the project on a quarterly basis. So for our submission to DOH on April 1st, we have to basically just go from that 6-month figure to quarterly figures. And we would like to tie each of those quarterly figures to a specific project implementation. So each project implementation team will complete the template, and you'll show over each quarter how many patients you expect will meet that actively engaged definition. one of the things that we don't need to do is we don't need to worry about trying to make sure that the sum total of the actively engaged across all of our implementations equals exactly the figures that are given here. So I think that would be just unnecessarily difficult of a task in order to make them force it to add up to the numbers given here. Again, the numbers given are the minimum network-wide commitments, and what we're expecting is that as each implementation really thinks about their specific capacity in relation to that project definition and fills out their commitments by quarter over time, as all those templates come back to us, I think the totals are most likely going to exceed the numbers that you see here. And that's a good thing. We're happy to have them exceed. If for some reason they don't reach these figures, we'll certainly come back to you as a team and try to figure out where to go from there. But at this point in time, just think carefully about the capacity of the project that you're part of, and come to some conclusions as to how many patients you would like to commit to being able to achieve the actively engaged definition by quarter over the length of the project. In a subsequent slide, I'll have for you the calendar that shows how the DSRIP years line up with the calendar years. So you'll have that as a reference. Up at the top of the speed and scale template, you'll see that the red numbers, again, are the ones that we submitted back in January. The way that we came to those numbers is we had on our templates from you, we had your commitments to the different behavioral health primary care implementations, and based on which organizations had committed to be part of those, we then cross-referenced that with a table of organizations by type that was actually given to us by the Department of Health. So we didn't categorize you into these different buckets you see off at the left, PCP, non-PCP, clinic, and so on. What happened was, based on the Medicaid IDs that we had submitted to the Department of Health, they basically spit back to us a table giving us those numbers, saying this is how many in your network you have of each of these types. We then compared that to the templates that you gave us, and we're able to break it out into the different buckets that you see here. So what you're really seeing is that what the PPS network committed to for behavioral health primary care integration was we committed that by the end of the second quarter of DSRIP year 4, all of the participating partners will have met all of the project requirements. So that's what they're looking for in speed. They want to know the point in time that we expect that all of the participating partners will have met all of the project requirements. For our next submission, they would like us to break that out and show them how, over the course of time, we're going to build to that final number that you see here during DSRIP year 4, quarter 2. So what they're asking us to do is to sort of show like a ramp up or a scaling up of the project over time. Back, again, the templates you submitted in the past, you had made some commitments that might have been at an earlier point in time. And now this is your opportunity to kind of revisit those commitments that you made, determine if that's still the point in time that you want to commit as an organization to having met all of the requirements. The latest point in time that you could commit is where the red numbers appear. You may want to make an earlier commitment, and in fact, you may have already done so back in your December template. So we've been asked by the different project teams to provide back to you as a reference the information that you would have submitted, that you did submit to us back in December when you were first doing your project planning. So we have summed up that information. It's basically just a Word document showing you back the tables you gave us. And I was going to say later today, I'm going to say tomorrow. Tomorrow we will have posted on our website that reference document as well as a speed and scale template for each project team to complete. That information will be gathered up by us from all the different organizations that are participating in this project, and then we'll submit it again on a summary basis to the Department of Health. We won't expect you to be able to fill out the speed section of the table for each of the provider types that are given. Again, that was something that we could determine from some data that DOH provided back to us. What we will do is we'll ask for your speed commitments by partner organization, just like we did back in December. So the template you'll get will show, instead of showing those provider types, there'll just be a spot there where the organization is listed, say a given behavioral health organization that's part of the project, and that organization will just be able to indicate their speed commitment according to the timeline. We're about to start DSRIP year 1. It's a short year, meaning that it's only a in DSRIP years, it's a short year. It's a 9-month year, and it begins April 1st, 2015. Following that, year 2, DSRIP year 2 is 2016, and so on. It just follows calendar years after that. Okay. So before I speak about the work plan, in summary, looking back at the last few slides, there are 2 items. One is a budget, one is a speed and scale template. Those 2 items are both due to AHI on March 13th. The information from both of those informs the application that we have to submit on April 1st. In addition, we're looking for project teams to develop work plans. The work plans are not part of the April 1st submission. So you have more time to do the work plans. The work plans, we're looking for those to be submitted to AHI by April 22nd. At this point in the work planning process, we're looking for what I would call a high-level work plan that outlines the steps that need to be taken to meet each project requirement. So again, it's those same requirements that are in the requirements, milestones, and metrics document that DOH put out last year. Your work plan template will simply show each of those requirements and milestones, and there'll be a spot for the steps and the target date for completion of those steps to be filled in. The overall goal is for there to be a single high-level work plan that applies to the project as a whole in all the regions, so that we have common elements or certain core elements that every implementation of the project is working towards, the steps that everybody needs to take to get towards those same requirements. We recognize there'll be a more detailed level that you'll need to have to implement the project in your specific region, but the requirements are common to all the projects, and so we expect there will be some steps and target dates that are also common to all the projects. At this point in time, we did get some feedback that the teams wanted to be working together and not be kind of siloed off in their own regions. So we decided to move forward with these regional project teams. But there are a couple of roles that are not filled when it comes to the project teams. So one of those roles is the role of project champion. Each project team really needs a project champion. AHI's role, our role is more, I would call it network development and project management, but we're really looking to the healthcare providers and partners that are implementing these projects to really provide that level of leadership. AHI will provide project management supports. So we're in the process of recruiting project managers. We're going to need many. Fortunately, for the behavioral health projects, we do have a project manager who worked with your teams, with many of you, not all of you, but worked with many of you last year. So that's Heather Bradley. So Heather Bradley has been promoted from her position of network coordinator to project manager. She'll be working very closely with this team as well as the crisis stabilization and ambulatory detox teams. So Heather will be in the position of supporting the team in terms of keeping up to speed on all the requirements and guidance that constantly is coming out of the Department of Health. She'll be monitoring all that information, making sure that the project champion is aware of any new developments. She'll handle the meeting planning and team communications. She'll be in the position of producing the reports from our performance management system, as well as any other materials that the team might need to do their work. And she'll handle the kind of day-to-day documentation that happens in the DISRP tracker, which is our performance monitoring tool. So it'll be a great deal of project management support. And while Heather does have a background in mental health and addiction services, we still would like to have, in addition to project management, we would like the team to really have a devoted project champion, someone who can provide network-wide leadership over the project. This person would participate in statewide learning collaboratives, would be aware of what needs to be produced by the team, and would kind of guide the agenda and facilitation of meetings, again with the actual project management supports happening here from AHI. So we're developing a scope of work for the project champion position. We'd expect the time commitment, especially in this first year, given the amount of work that needs to be done with the implementations. We'd expect that the time commitment would be approximately 1 day per week, and it's valued at approximately $20,000 annually. So those monies are monies that we've set aside from the current planning grant. I know many of you are aware that the first planning grant that we applied for wraps up at the end of March, but that we were awarded an additional planning grant, and we felt it was very important with those planning dollars to ensure that we had project champions whose time was funded, so they could really dedicate time to developing and leading the projects. So should you have an interest in being a project champion, please simply send me an email or give me a call, and we'll go from there. So we do need those project champions. So at this point in time, these are the things that we're working on in March. On March 9th, the PPS has to submit any additional partner information to the DOH. So there is an opportunity for organizations that are not already part of the PPS to join the PPS. We're working to look at the network membership, determine if there are any gaps, and we'll do some outreach if we need to bring in some additional partners. So if you know of anybody, if you know of any organization that's not currently part, that please have them get in touch with us. The important thing for the project teams in terms of deadlines is this March 13th deadline. So March 13th, we're looking for the budget templates and the speed and scale implementation templates. As I said earlier, the budget information is already available on the AHI website, so you can get those templates. You can get those templates out, and they're ready to work with. Tomorrow, we will be posting on our website these slides, as well as the recording and your speed and scale template, as well as that reference document of the information the teams had submitted last December. So if you want to look back at what did we say before about speed and scale, because I really wasn't 100% clear then, and what did I say and what do I really want it to be now, and make those adjustments, you'll have that reference document there, as well as the template that needs to come back to us. We'll take that information. It'll be part of the draft implementation that we submit to KPMG on March 16th. KPMG is the DISRP support team that provides feedback to the PPS on their progress. We'll take their feedback and finalize our implementation plan that is due to DOH on April 1st. So I think I just want to take a step back and give you a little bit of insight into that April 1st submission. So I've received a fair amount of questions about it. I think that it was surprising to us, and it may be to you as well, really how little information on the projects is going into that April 1st submission. They're really just asking us to take those speed and scale commitments and get a little more detailed about them. They're not asking for a work plan. They are asking for a budget. The budget that they're looking for is really that project budget category for the PPS network as a whole. So the information that we get from you about budget, that'll all go through the finance work group, and the finance work group will evaluate the different budget requirements that they're seeing from the projects, and they'll be in the position of determining the amount of funds that they want to allocate at this point in time to that project budget line item. So again, the budgeting is iterative. This is just a first ask. There will be a more detailed ask, at a later point in time. So even though the Department of Health isn't looking for a lot of work plan detail in that April 1st submission, we know that we need to move forward with getting work plans in place so that we're able to start taking those steps towards meeting the project requirements. So we do still need work plans. It's just that they're not part of the April 1st submission. And that work plan template, those will be posted. The work plan template will be posted on the 6th. That's the date that we're anticipating releasing the work plan templates, March 6th. And really, that's just going to be the project requirements with a spot for you to put in steps and projected dates of achieving those steps. And you'll be provided with a draft that shows some potential steps. So the teams will really be asked to to finalize those. So as I mentioned earlier, we need to be able, in terms of our reporting to the Department of Health, we need to get to the point where we have a single high-level work plan that's common across all the implementations. But given that the project team, at this point in time, you do have a project manager, we don't have a project champion, and the planning to date has taken place in the regional teams. We'd like to hear a little bit from you during the Q&A, if possible, about how you want to approach that. So, one option is you could do your work plans through your regional teams, the same teams that you worked with when you put together your plans back in December. You could each do work plans. We could then take those work plans, look at them for some common elements, and produce a more solid version of a network-wide work plan for you to respond to. Alternatively, you could work together on that high-level work plan now instead of doing them individually in your regions. If you want to work on that high-level work plan now, it'll be a bit of a challenge until we get a project champion in place who's leading the group, but we can facilitate that if there's strong interest in going that route. So we'd be happy to hear your feedback on that during the question and answer part. And now what you'll see on your screen is the link that you would follow to connect to the MIX. The MIX is a website that the Department of Health has established. It stands for Medicaid Redesign Team Innovation Exchange. The MIX is, the DOH has established it, and they're relying on it more and more heavily as their mechanism for communicating with the PPSs. So I've got an account. I've logged in a few times. There are a lot. You can join different groups, and you can kind of see what other PPSs are doing. It really does facilitate sharing of information and communication with other PPSs. In addition, we're told that through the MIX, the PPS itself can create a closed group and use it for our internal communications. So we'll be talking with our district support team consultant and getting some directions on how to do that and leverage that for the communications going forward. I know it's a bit cumbersome with the blog and getting the email alerts that there's something there and the downloads and so on. So we are looking to see how we can leverage this MIX platform to improve those communications since it's available immediately. And so I would strongly encourage you to go ahead and create an account. There's nothing specific to AHI there right now, but we expect there will be shortly. So please go ahead and follow that link and get an account set up on the Mix. It'll be a good tool for the team to communicate with each other. And at this point in time, we're going to open it for questions. I see a couple of questions have come in, and you can either type in a question or you can raise your hand and I can unmute you. So the question that's been submitted is regarding the counting methodology. If you engage a client in the first year and they continue to receive services in the following year, can you count that person in each of those 2 years? And the answer to that question is yes. You can't count the same person more than once within a given year, but that same person could be counted again the following year. So you can think of the actively engaged methodology as kind of representing in a given year the total services or total capacity of the project during that year. And certainly some of those same people will be part of that total capacity or total services each year. Not seeing any hands raised or any questions regarding or comments, regarding how to approach those work plans. I think we will just go ahead and say that the way to proceed, that the way we plan on proceeding with work plans is for each team, each implementation team. Oh, I am getting, okay. So I do have one person advocating for more of a regional work planning process than for an individual or I should say than a local approach. You know what? I'm thinking as we get used to using this GoToWebinar, next time around we'll learn how to do the poll. So I could have polled the group instead of having you had to raise your hand or chat. So I do have one person advocating for a regional work planning process as opposed to working in the individual teams that you had done last winter. And as a follow-up to that, I think where to go from here would be tomorrow. The Regional Health Innovation Team leaders have their weekly phone call, and I'll bring that topic up with them, and we'll determine how to move forward. Okay. Seeing no more questions, no more hands raised, we will close the webinar, and thank you for your participation.